All right, everyone who is here with us again today, continuing in our discussion of pandemic preparedness and what must be done to prepare for the next pandemic. I know that for those who were able to join for the last session, especially, there are a lot of grave and deep concerns as we look at where we are and what needs to be done. I'm really happy that we're moving into this session, which we've called Preparing the Next Generation of Pandemic Responders, because I do believe, for me personally, that if something is going to give me hope and optimism in the midst of what we are currently facing, thinking about the next generation and groups of responders and how we can best equip them is forefront in my mind for sources of hope and where we would move in that way. My name is Dr. Rachel Vreeman again. I'm the chair of the Department of Global Health at the Icahn School of Medicine at Mount Sinai and the director of the Arnhold Institute for Global Health. We're delighted to be convening this virtual webinar session and symposium today around pandemic preparedness. I do want to mention to everyone who's joining us, we do welcome for you to type questions that you may have into the Q&A box that you should be able to see at the bottom of your screen. Towards the end of our hour, we'll turn to those and try to respond to a number of them. So please do feel free to put questions there. And again, in this panel, we are going to focus together on how healthcare workers across a range of educational backgrounds and training can be best prepared to respond to future pandemics. I'm really delighted to welcome the group of experts that we have with us today. Let me go through some introductions for our new panel here. So first of all, we have Professor and Dean Paul Ayuo, who is here with us. Dr. Ayuo is an internal medicine physician who has a long history of building and leading medical education programs, particularly in Kenya and at the Moi University School of Medicine and College of Health Sciences in Western Kenya. He established the first Masters of Medicine program in internal medicine and the Masters of Medicine and Family Medicine programs in East Africa. He's headed the undergraduate and postgraduate curricula implementation for the university in Western Kenya. Professor Ayuo has been both the chair of the Department of Medicine and the dean of the School of Medicine at Moi University, as well as a member of the Moi University Management Board. He has considerable experience in educating health professionals and training, as well as administrative leadership through these multiple years of training, particularly at the medical school and the College of Health Sciences. He's also been the head of the AMPATH Training Institute in the collaboration that, if you were with us earlier, you heard Dr. Gardner introduce and refer to, called AMPATH, the academic model providing access to healthcare. And I'm personally privileged to have known him for quite a number of years through my own work in this Kenya partnership. Professor Ayuo also has a clinical care background, of course, not only as a physician, but with a specific clinical interest in gastroenterology and hepatology. And his expertise in medical education is evidenced by his role as an external examiner for medical schools for university, both within the country of Kenya and also beyond in places like Tanzania and Namibia. So welcome, Professor Ayuo. We especially appreciate you being willing to join us at such a late hour in Kenya today, and really thank you for that time with us. Next.
Good evening, everybody. Good morning.
Thank
you, Rachel, for having me.
Thank you, Prof. Ayuo, and good evening to you. We have to hear. Also joining us at a late hour where he is and from a long distance is Dr. Baraj Karmacharya. We are grateful for having you here with us. Dr. Karmacharya is the director of the Public Health and Community Programs and an associate professor at the Department of Public Health at the Dulakel Hospital of Kathmandu University School of Medical Sciences in Nepal. He obtained his master's degree in medicine from Kathmandu University. He also has a PhD from the University of Washington in Seattle in the United States. Dr. Karmacharya was the founding member and has led the Department of Community Programs since 2006. He also leads the Nepal Technology Innovation Center at Kathmandu University, which is a particular platform for bringing academia and industries together for rural development. Dr. Karmacharya is engaged in developing and setting up innovative community-based health and integrated health and development programs across rural settings in Nepal. And again, we just thank you so much for being willing to share your expertise with us today. And again, at a late hour in Nepal, but we're so grateful to have you join us virtually for this time as well.
Thank you for the opportunity.
Great, thank you. And then rounding out our group for the panel for this session is Dr. Nils Hennig. Dr. Hennig is here with us in New York City at the moment, so he has a time zone advantage in that sense. But Dr. Hennig is the director of the Masters of Public Health program here at the Mount Sinai School of Medicine, and he's the associate director for the Mount Sinai Global Health Center with that. He is an expert in humanitarian aid, infectious diseases, and public health with also broad international health experience. He's worked over the past 15 years as a physician, medical director, and research coordinator and medical consultant for Médecins Sans Frontières, or Doctors Without Borders, Médecins du Monde, Doctors of the World, for the Malaria Emergency Technical and Operational Response, or Mentor Program, the Fogarty International Center of the National Institutes of Health, Earth Rights International, Progetto, Zingo, and other international organizations in humanitarian emergencies, fact-finding missions, development, and research in more than 18 countries around the world. Dr. Hennig has a long record of training medical and public health staff through these international organizations and ministries of health and public health. And in his role as a director of the Masters of Public Health program at Mount Sinai, oversees the education of a generation of skilled, dedicated public health professionals as well. We also particularly connect because Dr. Hennig works clinically as an attending in the pediatric HIV and AIDS clinic at Mount Sinai. As a pediatrician myself, I'm always excited to have other pediatric focused people with us. And of course, with my work overlapping in HIV as well, I'm always grateful for his insight and work related to the care of infants, children, and adolescents as we both educate and do research and move forward. So again, I'm really delighted to have all of you with us today. I'm going to ask each of you individually to share a bit about some particular insights from the settings in which you're working and the perspective that you have, particularly again related to training and educational programs and how we think about pandemic preparedness for the future. So Professor Ayuo, we'll start with you. Can you please share a bit about how the COVID-19 pandemic has transformed the education for students at the Moy University College of Health Sciences?
Thank you again, Rachel, and thank you for that extensive or very, very long introduction, which I don't know who wrote it, but be that as it may, I'm happy to participate in this discussion of this very pertinent issue. When I think we go back to around about March 2020, but you forgive me because I got a running nose, but it's not COVID though. And March 2020, we closed all our institutions and we had started lockdowns. So at that time, we sent all our learners and lecturers home. So the first impact we have seen is about delayed progression. Although our curriculum, our programs had delayed a bit, but now again, the COVID lockdown caused us another almost academic year in delay in the progression of our students. Number two is that when we started opening around about August last year. And now, since we are trying to avoid large group gatherings and our classes normally get overcrowded, for courses that do not require hands-on like clinical bedside teaching, we have now adopted and we are learning very fast. In fact, we use IT, we are using Zoom, we are using Google groups and all kinds of electronic meeting programs. So I think that's one of the major impacts that now, although we had been talking about it for a long time, we've seen that courses like biomedical sciences, which do not require patience and so on, are all now being carried through IT interactions. And that's a major, major impact. And I think we can say COVID has accelerated what we're already thinking about. Number two is about, I think this is three, about our teaching in clinical areas. I think this is the major impact, which might be negative, because at first the lockdown affected our patient loads in the clinical areas. So when the students came back, we didn't even have enough patients for the students to work with. Number two, which is of concern, since when we open, we still don't, up to now, we don't have the vaccine. So people who are high risk for serious illnesses, uh, the presenter currently talking included, are so shy to go to the clinical areas. And this will result in students missing out on other aspects of clinical teaching, because I don't want to use the word elderly because I think I'm still young, but people of high risk probably are not, if they're there for a very short time, and students will not get as detailed coaching as they require. And I think this is good and bad. Good in the sense that the student will develop the culture that you have been training them to do, self-directed learning issues, and they tend to work harder on their own than before. I think those are basically the most important impacts that I've seen. Thank you.
Yes, thank you so much for sharing that from your perspective, Prof. Ayuo. Dr. Karmacharya, could you please share with us a bit about how COVID-19 has impacted both the healthcare delivery and the educational options, especially thinking about your community health programs at Dulakal Hospital in Nepal, and how you are hoping to continue to train whether community health workers or others as we move forward?
Yeah, thank you very much for the question. In terms of the impact, obviously it had a tremendous impact. I'd first start with the training programs. It completely, and I used to say that it was very much like being caught up in a war when you are not prepared, and you have to rise up and assemble whatever ammunition you have around you. So it was very much like that situation when we started facing the COVID scenario here. And one thing that was very critical for us, was the agility of all the team members, and how we had to redefine our roles and responsibilities. And retrospectively thinking, I think we did pretty good in that. So in terms of the traditional, teaching and learning programs, classes and lectures, of course, they were disrupted. We did go into the online system very rapidly, and the transition was surprisingly pretty smooth. But I would rather like to highlight another component of the impact, and I would say that this crisis helped us understand, and also it helped us enlighten to others the broader roles of us as mentors, and also our students as the professionals. And the role was how to define, how to position ourselves in the place where we can have the greatest impact. And I think retrospectively thinking, I think we did pretty good in that. So within days, we redefined the roles and responsibilities of the faculty members, the staffs, the interns, and so on. So I'll just give you an example. We had to set up overnight the PCR booths and the swab collection teams, and we had our whole batch of like dental students and medical interns lined up, and and having rotational duties for that. Similarly, we had to set up like several triage and other facilities, and we had students all trained and reorganized in those activities. So I'd say that this was a tremendous opportunity for all of us to understand our greater role, beyond our traditional teaching and learning, and then how to position ourselves in such circumstances. I think that was a fantastic learning that you can't teach in class. And in terms of the community health workers and other health professionals working in the rural communities, I think it was also I would say an awakening moment to realize that that this pandemic is not just a health affair. It is a broader affair than that. And what we did very rapidly was partner with other stakeholders, the local community clubs, security forces, the local government, government health entities, schools, and so on. So they had to reach out and be proactive in terms of getting these different stakeholders involved in addressing the pandemic preparedness and management. For example, in a lot of our schools were turned into quarantine facilities overnight. And then a lot of the health facilities and even hotels and lodges had to be turned into isolation facilities. And so it was not a time to find out, to find out the things that made us different. It was the time to find out the things that united us. And I think that was a big learning for our community health workers and other professionals as well. So I would consider, in summary, that this whole disaster was also a great learning opportunity in these areas.
Thank you so much. That's really insightful in terms of the lessons learned, especially that we can carry forward in that way, and hopeful in that as well. Dr. Hennig, turning to you as an educator here at Mount Sinai in New York City, how has the public health education been shifted as a result of the pandemic, and what do you see from that as to what lessons might be learned or what could be done in the future as we consider how to best equip medical, global, and public health professionals?
Yeah, first of all, thanks for the invitation. It's really a timely topic, and there were some great speakers, and I'm honored to be on this panel with my co-panelists here. Thanks a lot. So I think it's a two-part question, so I will start with what we have done already here at Mount Sinai. And I think I also just want to set the setting. We really have to remember the situation last March and April, when our health system went from the first COVID-19 case to over 2,000 admitted patients within just a few weeks. And as a public health program, our responsibility was teaching public health and responding to the pandemic basically at the same time. So our students, while they were still attending virtual classes, they also became part of the COVID-19 student workforce supporting the Mount Sinai health system here. And they were employed in 6 areas: in pharmacy, in administrative services, in hospital operations, in telehealth, in laboratory work, and in moral. So our students assisted filing various needs throughout the Mount Sinai health system, contributing to patients' care and combating the spread of COVID-19. So they actually participated in one of the most important strategies to expand and strengthen health system capacity in a public health emergency, sharing and shifting tasks to maintain essential health care. So in this task of shifting and task sharing is a very concrete example how, as part of the pandemic response, we kind of adjusted our training to kind of, enabling our students to do both. And another very concrete example was our emerging topics COVID-19 course. Nowadays, mathematical models are being used to help inform public health decisions. So our students, they work with our faculty who actually developed these models using the daily incoming COVID data. And so the students, they kind of learned firsthand how our current disease monitoring structure is set up and how it kind of shaped our policy and decision-making on the local, state, federal, and also global level. The second part of your question was, what has to be done in the future, and also just a few thoughts on that one. I think, and we heard that from previous speakers before, we really need an honest post-mortem study of the pandemic, and that is not to point fingers, but really to avoid mistakes and learn for the future. I think the pandemic really has exposed America's deep economic and racial inequalities. And just to give one example, I mean, the age-adjusted COVID-19 associated hospitalization rates by race and ethnicity and are over 400% higher for Hispanics, American Indians, and Blacks compared with non-Hispanic whites. So public health education has to address, the systematic issues behind those numbers. And yeah, the US has a deeply fragmented healthcare system, which lacks incentives to address the social determinants of health. And financing also has to be addressed. I mean, here in New York City, the community health centers, they really had to follow staff during a national emergency while our healthcare resources were overwhelmed. And now with less staff, they're actually asked to implement a mass immunization campaign on top of their usual work. So, and I think some of the providers here in the audience today, they probably remember that some of the last words from the corona patients before here in New York, before they were put on a ventilator, were like questions like, who's going to pay for it? So, just an example that public health training really has to address the system issues. And then we really also have to teach building solidarity. I think social solidarity is a critical tool in the response to the COVID-19 pandemic. Health experts and political leaders, they call for major disruptive changes to everyday life and sacrifices for the collective well-being. So strategies to foster solidarity, they include like public messaging, such as a linked fate, or policies such as fair and transparent rules, and also sustained economic support. So promoting solidarity must really supplement any technical solutions, because the efficacy of the latter really depends on the former. And I think that is especially important in an open society if we want to continue to be an open society. Then let's talk briefly about the global public health training concerns. I mean, as we know, the coronavirus has crippled some of the most advanced health system in the world. But those were countries with social safety nets, where people have access to running water and, where they have space to self-isolate. But what about places, with much more fragile health systems and, no or very limited safety nets? And I think there are kind of 5 key global training concerns regarding COVID-19. One is really protecting the vulnerable people, like our trainees. They should be concerned how people living in overcrowded conditions on the streets and in refugee camps or in substandard housing are affected by the pandemic. And social distancing is infinitely more difficult or really impossible for those groups of people. Then, they have to talk about maintaining healthcare. During the pandemic, babies are still being born, people still need treatment for HIV and TB. And you probably know that a lot of the basic immunizations programs were actually stopped worldwide during the pandemic. Then we have to protect the healthcare workers. Shortages of PPE, they pose a great threat. So supply chain management in resource-poor setting is public health work, and we have to train people on this. And then we have to obviously protect the people most at risk. That's the elderly, it's people in institution, people with diabetes, with HIV, with tuberculosis, I mentioned it. And we still don't really know how does it impact with children with severe malnutrition. I'm just thinking on the evolving situation in Ethiopia, for example, right now. Those things, we really have to look into it. And the last is really no profiteering. There should be no profiteering on emerging drugs, tests, vaccines, and other tools. So our trainees, they must learn the necessary measures, and that include overriding patents and other monopolies, introducing price controls, really to ensure supply and availability of essential tool at an affordable price for all. And finally, we have to learn from success. I mean, there are role models who handled the pandemic well. And, for example, extensive public health infrastructure established in Taiwan, pre-COVID enabled a fast coordinated response there, particularly in the domains of early screening, effective methods for isolation and quarantines, and digital technologies for identifying potential cases and mass use. So in a timely and vigorous response allowed Taiwan to really avoid a national lockdown. I mean, Taiwan, I think the total death toll from COVID-19 stands at seven, like compared with 400,000 here. So yeah, so there are models we really have to learn from.
Thank you so much, Dr. Hennig, and thank you to each of you for the insights and even this first introduction. There's so much I think we could talk about together. One question and kind of area I wanted us to perhaps wrestle with a bit as a group as we think about these educational questions and training and moving forward is really the ethical dilemma that I think we find ourselves in as we think about medical education in particular right now, as well as with various cadre of trainees across that. And you know what it looks like, particularly for them to participate in medical and public health care during a pandemic. You know, of course, we see debate in some settings and as the COVID-19 pandemic has progressed as to, you know, whether medical students, for example, should be participating in clinical rotations where they're caring for patients who are infected with COVID or where there's a high risk of exposure to COVID. There have been questions at different levels, such as for postgraduates or residents, as to whether, you know, that is then appropriate for them to have a higher level of risk exposure, and yet also recognizing that they do not necessarily have the same levels of responsibility perhaps as the faculty physicians do for care or for assuming risks on their own. These questions of PPE and availability and you know, also of close mentorship and supervision with it and so on. So I would love it if each of you, or kind of as you feel led, could talk a bit about some of the ethical dilemmas around this sort of risk versus the importance of training and preparing a medical and public health workforce to move forward and to respond to pandemics as well, in terms of, you know, who you think should be trained and why, and how in each of the settings where you're working, you've balanced that dilemma between the risks and the critical importance of both that training as well as what it requires to move a pandemic response forward. Really, whoever would like to start is welcome.
Let me start, since I was probably the first, not for any other reason. Actually, it's a fact that training a doctor or training a healthcare worker needs hands-on, and that's where we talk about clinical teaching, bedside teaching, and so on. And your argument that postgraduates in Kenya, our registrars, we call them registrars, are registered medical practitioners in their own right, and that they are obliged by the fact that they are licensed to practice medicine. And this, we cannot avoid exposure of our students to potentially infectious situations like in the ward and so on. But I also want to argue that the learners have higher risk than actually some of us who are the mentors. Because if you take a registrar, you know, our registrars, Rachel, they are probably the first line people to see these patients. So if there was a patient, excuse me, if there was a patient, then me, I would have already been forewarned before I reached to go and have the student. So the risk is there, and it's great on student and so on. And this is the following issues. I'm asking questions just to open a discussion. In Kenya, for example, our medical schools or our teaching hospitals are not resourced enough to fund the PPEs for students. So the students have to go on their own. And I'm seeing this like the phrase that is normally talked about in Kenya when you want to attack the government is that you are sending your soldiers to the front line without armor. So sending them there naked so that they can be easily killed or attacked. And the COVID is a potentially fatal infection. So when we send them there, we say you must attend your ward rounds, you must attend your clinics, and we're not seeing where they get their PPEs from. They have to get from their pocket. And you know how somehow, particularly medical students, some of them are so poor they have nothing to eat, and they're telling them they must have a mask, they must have a gown, they must have sanitizer at all times as they come to the ward. And that raises a big issue. What do we do? Do we as medical schools put that in the budget? And the schools are they're not even there. So what we did some time ago is that we as faculty did a fundraising to buy masks for our students when we were opening in August. And how that is sustainable, I don't know, but we insist they have to be there. We insist they must have protection. That's one. Number two is our government, our institutions have no health insurance, particularly for students. And just ordinary health insurance is not there. But for us faculty who are well insured, we don't have insurance against COVID. Once one is unfortunate enough to contract COVID, you are on your own resources. And that, imagine a student who has no insurance and also is poor. How do they cope? Why should we insist without providing them with this? Is that those are the ethical issues I'm seeing, and also uh, from the faculty point of view, or from the hospital management point of view, or from the licensing point of view, a registrar might just decide that, okay, this is too risky for me, I don't want to come to work. Would you punish that person, or would you just say, okay, you're protecting yourself because you'd rather have a living doctor than a dead doctor who was attending to a patient and so on. Such like issues, those are the ones we see as the major ethical issues that we are undergoing here. And also, I think just because of apprehension from staff, whether you have PPUs or not, I think most of the times we rely most on physical examination, and I don't think we're going to do as detailed physical exam as possible. We want to spend as little time as possible with a patient and move on, because the longer you stay, the more risk you can. So from where I sit, that those are the things that come to my mind when you talk about ethical issues. Thank you.
Thank you so much, Prof. Ayuo. I think that really highlights both the how grave the situation is and the many nuances of it for medical students, particularly, as well as for staff. I mean, the faculty to consider as well in these responses as well. Dr. Karmacharya, would you like to?
Yeah, so in our experience, I think we were very clear in two aspects. Number one, as as an organization, we have to be responsible, to do the best. Whereas that might not be an ideal at a given scenario, but at least to do the best, to provide the best of facilities in terms of the PPEs, the quarantine facilities, and if infected, the isolation facilities and others to the students. So we were very clear about it, and we did do that. So that was a fundamental aspect. And then the second thing we were also very clear was that this is a time when one has to take up new roles. So we really whereas we didn't really force, but we did strongly encourage and advised a lot of our, in fact, the residents were very much involved, and also the interns, and later on the students in different capacities. But not all of them were involved right from the beginning, and we had to expand the roles and responsibilities as the pandemic grew, and we had more cases to handle, and then we had more staffs who turned positive and were in isolation. So thinking back, I would say that, of course, there is an ethical dilemma about the involvement, but to think it one step higher, I think it is also a moral responsibility of any health professionals, and also anybody pursuing career in health profession, to be in the position where one can do the greatest benefit to others. I think that was the argument we all were very convinced about, and that was the argument we used to convince them. So I think with that we didn't have any additional ethical queries within us and with others, and I strongly believe that in terms of global health trainings as well, uh, we should not take it something um, as a luxury. It's a moral imperative now to participate uh, in incidents and in scenarios like this. It is a moral imperative, and that is something we need to teach as well. One has to grow beyond the boundaries, beyond your professional boundaries. Uh, and I think that's the message I want to convey.
Thank you so much. I really, I think that is a critical balance in this, and as you said, elevating it to a higher level too, to think of that moral imperative that comes with it as well. Dr. Hennig, would you like to add to these considerations at all? I know there was some of that in what you.
I do. I think it was actually very, very wise. I'm very happy that I'm part of it. It's really interesting. I actually wanted to build upon kind of, what there says. I think probably the most important thing about the ethical dilemmas is that we prepare our students to confront them. I remember, I was thinking, I remember as a young doctor, just after my training, I worked in Angola during the Civil War, and there doing our initial assessment, we really encountered thousands of severely malnourished civilians, and they were like too weak to move, just waiting to die. And those numbers, they were really overwhelming. For the first days and weeks, we kind of had to decide who to take with us for treatment and who to leave behind for a certain death. And I didn't really have any tools to guide my decisions, kind of on whom to leave behind and perish. And during the early COVID pandemic, I heard from colleagues in Italy that they had to address similar questions, like who gets priority to a ventilator. So in a pandemic or working in any resource poor setting in general, it really often comes down who lives and who dies. And those are really complex questions. So our trainees, they really should be familiar with ethical frameworks and algorithms that help decide who should, for example, should get a ventilator if you have limited resources. So we really have to learn to consider things which are kind of most important of value to us. And like some values that we kind of thought might consider as maximizing the number of years of lives that can save. But I really think the responsibility of educators is really to provide access to ethical frameworks for our trainees to prepare them better for these kinds of situations.
That's a critical addition to this discussion as well. I completely agree, and I think that is a really important framing in terms of the tool and the structure that's needed for preparation in this way. Let me just mention to the group that's joining us again that would be happy to have you put some questions into the Q&A box to type. We'll have some time to respond to those. In thinking through this. As an HIV physician and researcher myself, I've been very aware of the many comparisons that we've heard at different times between the HIV pandemic or epidemic and the COVID-19 pandemic globally. And of course, the viruses are very different in and of themselves, but for myself personally, during my the years in which I was in my medical training and residency were the late 1990s and early 2000s, and particularly in my experiences, even as a resident or registrar equivalent with the partnership in Kenya at Moi University, the needs and the urgent need for significant and systemic response to the HIV epidemic were really what guided my career choices moving forward. And I think that was true for a lot of trainees globally as they who were approaching medicine, and especially in global contexts where HIV was a significant issue at that time. And in many ways, it was actually what you were saying, Dr. Karmacharya, that sense that there is this moral imperative to address this urgent, devastating pandemic, which of course is one that continues to be quite dire and made only worse, of course, by the limitations of the pandemic. But you know, so thinking from my own experience and that of my peers during that particular time in history and the pandemic challenges we were grappling with at that point, I'd be interested to think with all of you in your context a bit as well about how some of these specific demands of the COVID-19 pandemic and what they're experiencing around them might be shaping the decisions of medical students, of public health students, of those who are considering community health work as well, in terms of how that's being shaped by their experiences now, and what we think, whether good or bad, how that might alter decisions and options and growth of our health systems moving forward as well. Anyone who wants to jump in would be welcome.
I mean,
so many things.
Mm-hmm.
Oh, there I go.
Dr. Hennig, you want to go ahead?
Then I must say I'm actually very optimistic looking at our students. I mean, during COVID, I mean, they really demonstrated the skills, insight, and compassion to make a difference. And kind of what you described about HIV, how it kind of had a big influence on you. I think that also applies to our students. They really became an essential part of the support system at Mount Sinai, which we really needed. We really needed them to save lives here. So I thought their action actually were extremely inspiring. And I also want to point out that they actually really stood in a huge contrast to the generation in charge here, at least in the US. The beginning of the pandemic, missed warning, there were conflicting messages, broken promises, really kind of a sickening combination of arrogance, ignorance, and incompetence, and the complete absence of moral leadership. So, from the leadership, the pandemic was really often reduced to public health relations issues. So for me, the students really also kind of stepped up and demonstrated kind of moral authority. So, I think that it's just for me, that was just super inspiring to see. So I'm really very optimistic when I think how the students were kind of shaped by it. I was actually kind of, I remember it's kind of clearly doing crazy times. We sometimes read poetry, and I remember kind of a thing from Allen Ginsberg, kind of what I read, that a teacher fails if he has not been surpassed by his students. So I kind of take this, as I kind of take comfort in this, because the students, they really did, and I think they will continue to do so.
Dr. Karmacharya, do you perhaps want to, I think it relates into this, there's a question that I think you were maybe interested in taking about how we might, as we consider this moral imperative and how it might impact students moving forward, how can we structure the educational system, even at a practical level to help with this process as well?
Yeah, I was actually trying to type the answer in the Q&A box. Thanks for this opportunity to speak out. Yeah, in my opinion, of course, that is difficult. But what one has to accept and understand is that whereas we aim for an ideal circumstance, to happen to provide the ideal teaching learning activities, life does not always get ideal scenarios, but the commitment to provide the best of out of a given circumstance, that should be there. So I think that was also an issue. There was also an issue when we had to have discussions with our students and interns and residents in the initial phases, where there were shortages of the PPEs and so on, and then we had to be very open about it and say that, look, there is some risk associated with it. We cannot fully guarantee that you are completely protected. But I think the commitment to provide the best, and then to ensure them that we are not exploiting them, and we did that by showing up ourselves also on the same floor with them. It was not that we put them forward and then we are in safer situation. So I think one has to understand that humility is very important, number one. And I think number two is, as I reflected earlier, um, uh, I think some of the some of the strictness of the teaching learning activities need to be slightly diffused to adjust with the given circumstances. I'll give you an example. You know, so for example, with the public health students, you know, whereas we had to stop taking classes for some weeks because we were too engaged, we did involve them in the massive case investigation and contact tracing activities, and you know, the realization of that moral responsibility as health professionals was very critical. So we kind of redesigned one part of our curriculum in such a way that the period of pandemic in the contact tracing was counted as credit, you know, for that particular course. So I think that that flexibility is important.
Dr. Ayuo, would you like to add any to this from your long experience of training up students in Kenya, as well as your pivotal role in building both the medical education and health system there?
I'm losing everybody.
Oh no, were you able to hear what I asked? I can repeat it if that's helpful.
Yeah, please, Adi.
Sure. So I was saying, you know,
Please repeat.
from your long view in Kenya with building up a medical school and a health system, I wondered if you wanted to add in that sense of how you think the decisions and the orientation of the trainees by their experiences through this pandemic might shape the future for them as well. I believe you're muted now. There you go.
Thank you, thank you. I think our experience in Kenya of the recent past, I think that we got a problem with the employment opportunities. And we look at people, high school leavers now, they choose courses where they can easily get a job, not because they like that profession or not. But with the COVID, I think it's going to filter this so that, because it's an infection nobody wants to get. So people will be afraid of becoming healthcare providers. So unless you have a heart for being a healthcare provider, some of these people now will be avoiding. So it's going kind of weed people and to get people who are really committed to healthcare, working and helping others in times of epidemics, in times of pandemics, or in any good times. So I think that's one of the ways going to shape the people. So we are going to end up with fewer applicants for medical schools and healthcare provision professions. Other thing is, we as faculty, as teachers, we also must also kind of adapt, like Dr. Karmacharya's experience teaches us that we must adopt and we must come to some understanding, or must display that humility to these students, say that this is dangerous, but I'm also there, we are there with you, and they get more experience as they get mentored with people who have already have come to their level and say we want to work this together. That's what I can add for that question.
Yeah, no, I think that that's a critical point too, and I'm struck that it's not, of course, when we talk about these things, not just adapting, curriculum and asking for more resilience from students and trainees, but in fact, that we need to truly consider the many, challenges, demands, risks that they're facing, and how we can best support them throughout this. There's a question, I think that perhaps as our last question might be an interesting one to address as a group, recognizing Dr. Hennig's mention of the solidarity approaches and noting that there is a huge interest among students in solidarity approaches and catalyzed in part by the ruthless inequities of COVID. And noting in the question, there's a structural bottleneck often for mentorship, which is that medical students may not be acknowledging global activities or local activism, advocacy, policy efforts as part of how they consider promotions and sort of what kind of work is given credit for. And noting that often academic colleagues who are working part-time as advocates may have those efforts unrecognized by their institutions. So the question is, from a training perspective, what do you think about creating a track for faculty that would be focused more around activism and advocacy, in addition to what we think of for investigators and research, or clinicians and educators, or clinical innovators and leaders, as we typically see in academic health centers? What might we structure options for that kind of advocacy or solidarity approach into our academic medical centers? Maybe even if one of you wants to offer a thought, just knowing our time here. So,
I mean, just very briefly, I mean, it is an excellent idea. And it comes back to what I mentioned earlier. I mean, there are really structural problems with this. I mean, like as an example in the past, when I hear there's kind of with research for gun control, like because the NIH would not provide money for this kind of research, so no dean would hire an expert because they couldn't get NIH grants. And that is the same thing. In the end, it really needs a structural shift, that kind of building solidarity is an acknowledged, purposeful, excellent public health tool. It has to be a perfect public health tool if we want to continue living in an open society. I mean, if those of us who were earlier here today, when Gail talked about China, what they have done, we have to acknowledge certain things we cannot just implement. If we want to be an open society, there is a need for solidarity, and people have to understand why they have to do things. I mean, I think it's really critical for us, but it does need a structural change in our education system. But an excellent idea from the students. Excellent.
Let's.
I want to add.
Oh, go ahead, please.
Yeah, sorry. I'll just take like 30 seconds. Thanks, Duncan, for the question. It's not very intuitive, but the unfortunate thing is that the academia is sometimes the most conservative community. Mm-hmm. And they are they are the ones least likely to get out of the box. So I think one message we learned from the COVID-19 experience is that, this is not going to hold for a long time. We need to get out of the box and participate in terms of connecting with the government, other stakeholders, and of course, acknowledge all these activities in terms of advocacy and partnerships with other entities that are not traditionally academia, like communities. So I think we really need to revisit about the priorities and the focus, the areas of focus, where the academia should have in coming days, if we are to address scenarios like this.
Terrific. Well, to wrap up our time together, I'd like to ask each of you to close with just one sentence about what is giving you hope as we consider how we move forward, our ability to respond to global pandemics. Professor Ayuo, should we start with you?
Yes, one sentence is rather too short, but I think the world now has developed technologically much more advanced than before, and this is exemplified by a few months into COVID. We have candidate vaccines in the hundreds. We have candidate therapeutic agents in the hundreds and so on. And I think the world is now alert so that to keep things, keep tabs on things, and that way, I think we can avert pandemic disasters in the future. That gives me hope.
Dr. Karmacharya, what is giving you hope as we move forward?
Yeah. um, the thing, in one sense, the thing that gives me hope is that, this new generation of people, coming in health professions, in academia, they are more aware about inequity, and they are more proactive, and in many ways, they are ready to break, the traditional boundaries for the larger cause of humanity than the preceding generation. That gives me the hope.
Completely agree. And Dr. Hennig, closing out our group here. Once,
And I mean, COVID-19, like all communicable diseases, it is a preventable disease. I think we have to keep that in mind. So we have to look at mistakes made, and we have to you have to invest in public health infrastructure and surveillance before an outbreak. I think,
thank you. Thank you so much to each of you for joining today, and especially a thank you with the time differences and the distance for joining. A reminder to everyone with us, we will be posting these recordings to YouTube. Please feel free to share the links. We will circulate them around and to share them with your networks. Our next session is going to be starting at 15 minutes past the next hour. That's 12:15 Eastern Standard Time. We're going to be looking at vaccine confidence and vaccine hesitancy and mistrust. I think it should be quite an interesting discussion as well. So please, take a moment for a break if you're staying with us, and we welcome you to return and rejoin at 12:15. Again, thank you so much to everyone with us today. It's very much appreciated.